Good afternoon, everybody. I'm Brian McHugh of McHugh Neurosurgery, and I'm coming to you today from the Good Samaritan Hospital here in West Islip. I'm here to give you a talk on general neck issues, specifically from a surgical perspective. First, I want to go over a little bit of the anatomy and the mechanics of your neck, and then we'll get into some fractures and trauma that can happen to the neck, which is always a concern, some of the common degenerative issues in the neck, and then lastly, some of the deformity work we've been working on with regards to the neck or cervical spine. So not to get too into the weeds on this, but I think it's interesting to learn for most folks that your neck is actually divided into three separate sections. There's sort of the top of the neck where it connects with the head or the skull, and we call that the occipital cervical junction. And that's important because a lot of the stability there actually comes from ligaments, not so much the bones of the neck. And so the injuries we see there, which are usually traumatic, are actually ligamentous tears rather than broken bones. So that can be a little bit disquieting to learn that the head is actually attached to the neck largely from soft tissues. Below that, we call the subaxial spine. That's because the C2 bone, or the second cervical vertebrae, is called the axis. So everything below that is subaxial. And that's what most people think of as their neck, because the junction between your neck and your skull is deep, almost behind your ear. So the main part of the neck is really the subaxial spine. That's where most of our degenerative disease and arthritis kicks in, where you get pinched nerves and issues like that. And then at the base of the neck, where it transitions from the neck into your sort of upper thorax or thoracic spine, we call that the junction, which is a critical component when it comes to an overall alignment of the neck, which is kind of the last part of this talk. So if we talk about the junction of the skull and the neck, we really get into all the ligaments that sort of tether the skull to the neck. And they're not critical. We won't lose you in the weeds on that. But it's just something to know, and there are some pictures there that kind of highlight those ligamentous attachments. And really those are tough pieces of leathery type tissue that strap the top part of the cervical bones to the bottom aspects of the skull. So it's holding the skull in place, essentially. There are various types of injuries you can get there in trauma situations like accidents, falls, etc. Most of those are, like I mentioned, damaging the ligaments. So you get dislocations, essentially. They're terrible injuries, but you can dislocate either the head from the neck itself or the top two bones of the neck. You can also get some fractures in that area, but it's less common. More commonly are these ligamentous injuries, which can be quite frightening. You can fracture the top bone, which is called the atlas, and you can also fracture the second bone. So C1 is the atlas, C2 is the axis. Both of those can be broken. I have a picture there. The common C2 injury is known as the hangman's injury because that was the way, unfortunately, you'd pass away if you ever hung from a rope. There are other ways to get that fracture, and it's been named after that. Some of the treatments we get into for these broken bones are collars, surgeries, and this sort of medieval device in the bottom right-hand corner of the slide, which is the halo device, where screws actually go into the skull and you wear this complex vest to keep the neck as immobile as it can be. With good luck, most of those injuries will heal on their own. If they're truly unstable, that's where a surgeon such as myself might get involved to surgically fixate an injury in the neck. Below those levels, down in the subaxial spine, you can injure the vertebral column or the neck, as we call it in layman's terms, in a variety of different ways as well. And there are a number of different classification systems we use in the trauma setting to label these injuries and ultimately decide if there's something that needs surgery, if there's something that we can treat in a cervical collar, or if it's something that may need that device we saw previously, the halo device. And we won't get into the details of the various classification schemes, but in general, we kind of divide them up into flexion injuries, where your head gets forced forward like this, and then also extension injuries, where your head gets forced backward like that. And then the other component is rotational injuries, where your head is forced to too far from one side to another. And there's a limit there where that's comfortable, and then when you're forced past that breaking limit, something's got to give, and it's either a joint, a bone, a ligament, something that ruptures. Obviously, these are quite painful, and when we look at them on the various imaging modalities we have, like x-rays and CAT scans and MRIs, we're looking at the various structures we just talked about to determine whether or not that's a stable or an unstable injury, and whether the spinal cord or the nerve roots are compressed in any way. And those are the types of parameters that go into surgical decision making. So a highly unstable injury where the spinal cord or the nerves are under pressure or compressed is probably something that's going to need surgery. Whereas a stable injury without any compression on any of the nervous structures is probably something that will heal just fine in a collar or a brace. I have a few examples here. This was a hyperextension type injury, and the patient, if you can look at the CT scan and the x-ray side by side, you'll note one of the bones has slipped forward a little bit. So they sort of fell down some stairs, slipped this bone forward. As we go to the next slide, anybody out there who's clinical will know the CT scan on the left shows something called a perched or locked facet joint in the back. You can kind of think of that like a dislocated shoulder. The neck itself is dislocated and stuck into position. We also got an MRI on this patient, which is on the right side, which shows some of the ligamentous tears and actually a hematoma in the central canal that's pressing on the spinal cord. So we needed to decompress this patient's spinal cord quickly, realign the spine, and fixate that into place because it's not stable, unfortunately. So it's a good example of a surgical traumatic neck injury. And we did that with a couple little pins from the back and some pins from the front too. So you end up with 2 incisions for a surgery like that. Here's a second case. This is an elderly gentleman who had a hyperextension injury, and there's not much to look at on that CT scan on the left side. We use this case to trick the medical students. If you look at the CT scan on the right side, you might notice just the slightest chip on the back side of one of those facet joints, which are those shingle-looking joints in the film there. That caught our eye, and when we went back to the initial CT scan on the left, we can see a little bit of a fish mouthing of one of the disc spaces there. So we said, let's check further with an upright x-ray. Those are interesting because you're bearing the weight of your head in those situations. And when we took a look at that, if you're not used to looking at these, it may not be obvious, but that whole segment of the neck dislocates, and that's an unstable issue for this patient. So he ultimately needed to have surgery to fix that as well, which we did through the front part of the neck. It's a very easy corridor to access, and there's a very low pain profile if you have to have surgery from the front of your neck, so don't get too concerned. We were able to fix that segment of his spine, and he did just great. That's just a slight overview on the types of traumatic injuries you can get to what we typically refer to as the neck. I think you now know that the neck itself isn't quite so simple. There's 3 segments: the junction between the skull and the neck, the part that we generally think of as the quote-unquote neck, which we call the subaxial spine, and then the part that junctions with the thoracic spine, the junctional segment of the cervical spine. So in that mid part of the neck, the subaxial region, what most of us think of as the true neck, that's where we get a lot of degenerative disease and arthritis, and that's really just a general wear and tear type breakdown of the soft tissues in the neck, like the discs and other cartilage structures, similar to knee arthritis or hip arthritis. The only difference with the neck is when that happens, if the discs bulge or little bone spurs form, they can press on the nerves or press on a spinal cord and cause shooting pain down into the arms, or general spinal cord dysfunction, which we call myelopathy, which can also leave you feeling kind of unsteady as you're walking. Some folks will have bad pain in the neck with severe spasms and tightness throughout the neck region, the upper shoulder region, and even down the upper part of the mid-back between the shoulder blades. That's all not uncommon in patients with bad neck arthritis. Occasionally, a neck is so stiff and arthritic that you'll also get something called a cervicogenic headache, which is where the arthritis or the pinched nerves in the neck actually cause the patient to complain of a headache as their reason for visiting the doctor. Typical treatment for degenerative disease is at least 6 weeks of what we call conservative therapy, and that's generally rest, ice, heat, physical therapy, non-invasive modalities like physical therapy or chiropractic care, acupuncture care, etc., anti-inflammatory medications. And you want to really commit to this to make sure the problem you're having isn't something that could be dealt with without an invasive procedure. But once that is something that's clearly failed for you, surgery becomes an option to relieve the symptoms and take the pressure off the nerves or alleviate arthritic joints. In general, we have 2 types of surgery for the subaxial spine: anterior surgery and posterior surgery from the back of the neck. As I talked about earlier, coming from the front of the neck has a pretty low pain profile and is a relatively bloodless type of surgery, so usually we prefer to go from the front of the neck if we can, although the data suggests as you have more and more levels that are a problem, it may become beneficial to come from the back or posterior side of the neck. When we do surgery from the front of the neck, in general, there are 2 types. The first type is a traditional fusion procedure that's sometimes called an ACDF, where the disc is removed, the bone spurs are drilled off, and then the 2 bones are fused together, typically with a little spacer in the place of the disc. More recently, we've developed motion-preserving technology, a disc replacement. The disc is still removed, the surgery is essentially the same, but instead of fusing the 2 bones together, we implant the device. This is an example of one called the Mobi-C, which is produced by Zimmer, which is a multi-conglomerate company that makes disc replacements. So that's one example that inserts into the space where the disc was, and it moves just like a natural disc. So if you're a candidate for that, we'd rather do that than fuse the bones. But there's a lot of nuance in deciding between one versus the other, and both are good options. And those are pictures of a patient with disc replacements on the left and a patient who had a traditional fusion surgery on the right. From the posterior side of the neck or the back of the neck, we can make small incisions and work through small tubes to do something called a simple foraminotomy. That's where we just decompress one pinched nerve from the back of the neck, a relatively minimally invasive procedure. Or you could have an open laminectomy where there's a midline incision made in the back of the neck and we remove some of the bone from the back side, which decompresses the spinal cord. Usually that's reserved for cases where we can't get to that pressure from the front, or when the pressure itself is coming from the back, so we want to come from the back to remove it. The only disadvantage to coming from the back is all the muscles are really in the back of your neck, so the incisions back there tend to hurt a little more than if you could have an incision in the front of your neck. A couple cases of kind of standard degenerative type problems. This is a patient with a disc herniation. You can kind of see it bulging out in the MRI view on the left side. It's contacting the spinal cord. It's pinching the nerves at that level. The spinal cord is indented. This patient had symptoms of neck pain, headaches, spasms and stiffness throughout this upper shoulder area called the trapezius, and shooting pains down into her arms that were getting worse despite her efforts with physical therapy, acupuncture, and chiropractic care. Once we got to that 6 to 8 week mark, we gave her the option of moving forward with surgery. Obviously, that wasn't something she wanted to hear necessarily, so she waited a few more weeks. Without success, unfortunately for her, she ultimately came to surgery. It's just a single level disc. We recommended the fusion procedure because of the malalignment she has at that level. That's ultimately a small procedure, relatively speaking. It takes about an hour. You usually go home the same day, and she recovered quite well. Her symptoms all dissipated, and she was able to return to a completely normal life. Here's an example of another patient who sort of acutely herniated a large disc down the lower part of his neck. You can see that on the MRI again on the left side of the screen. You see a lot of spinal cord compression there, and that's not okay for him. That's a dangerous situation. If the spinal cord is injured completely, the patient could end up paralyzed. This patient had a reasonable anatomy and other aspects of his case that made him a great candidate for a disc replacement, and that's exactly what you see put in place on that x-ray on the right side there. So it's a motion preserving technology for him. He gets to keep full range of motion of his neck, and he has a much less or lower likelihood of requiring future surgery as a result of the adjacent or neighboring segments breaking down, which is something that does happen, unfortunately, over a long period of time with the fusion procedure. Lastly, we kind of wanted to talk a little bit about cervical or neck-based deformity and the alignment goals we go for when we see patients with neck issues. Why is that important? Because it's relatively new. We've uncovered it over the past 10, 15 years. And a lot of times we're simply looking at the x-ray or the MRI of someone's neck, and if there isn't an obvious glaring problem like the last two cases, we tend to say, look, surgically there aren't issues here. What the latest research has shown us is if the alignment is off, meaning the center of gravity of your head typically is adjusted too far forward, as in the case with these pictures, that can drive a lot of neck pain, headache, and even sometimes low back pain, as is illustrated on this picture. If you look at the left side here, that's a skeleton with normal alignment in panel A, and then panel B is a patient with a neck that just angles far too forward. As a way to compensate for that, this patient is really leaning back to keep his gaze, his or her gaze, looking forward and walking in an upright position, but that generates a lot of back pain. So we'll see a lot of patients with neck and back pain, and if you just took an isolated picture of their cervical spine or their neck, either with an MRI or an x-ray, you may come to the false conclusion that they don't have a surgical problem or a structural issue, when in reality, if you look at the whole spine, top to bottom, they have an overall alignment problem. Another issue that comes to light with these patients is they'll sometimes present with back pain. And again, if you take an isolated film of their lower back, you may say, well, there's nothing really here structural that's explaining the back pain, so it must be muscular, and continue with physical therapy, even though that hasn't been working too great. When you look higher up and take a look at a standing, full-length x-ray, you see that really the problem's driven from a fundamental malalignment of their neck. We have a couple examples of patients with this issue, some on the small end, like this patient here on the left side. If you look, that's an x-ray with the patient facing to the left. They just don't have that normal curvature or C-shape to their spine. It's curving a little bit forward, and they had an awful lot of neck pain and some pinched nerves as well, so they ultimately got a fusion procedure. But I think you can see in the post-op film on the right the overall arch that's put back into the spine and realigns the head back over the center of gravity of the rest of the spine and keeps that neck pain at a minimum. Things can get a little bit more severe with certain patients. This is an unfortunate gentleman who has his spinal cord compressed, as well as the zigzag type shape throughout his neck. It's all degenerative disease, unfortunately. It just happened to go the wrong way for him. So we had to come up with a plan surgically to decompress his spinal cord and do our best to straighten out his spine. We needed to do that through a combination of anterior surgery as well as posterior surgery, but we're able to get a reasonable result on the right side with the x-ray that you're seeing post-operatively. And the patient did really well and went back to a full functional life. And then some of our most severe examples, such as this patient whose neck really at the cervical thoracic junction is fixed into this 90-degree position where he's forced to stare at the ground all day. Obviously that creates both functional issues, as it's difficult to get around and maneuver. Imagine trying to reach for anything up over your head. Just going to the grocery store would be challenging, not to mention the pain from being positioned like that all the time. It creates great fatigue and inflammation in the cervical musculature and upper shoulders. And so we're able, through a series of larger operations that fall under the deformity category of things, perform a corrective type maneuver to pull the head back upright and ultimately fix it into a position where it's looking forward and the patient's comfortable. Ultimately, those patients do quite well also, although they do have a longer recovery given the relatively larger surgery they required. So that's most of what we wanted to review with you today. Just a quick overview of what we generally think of as our neck. Not as simple as it sounds. Hopefully you walked away remembering there's really a couple different parts to what you think of as your neck. The junction between the skull and the top of the cervical spine, that midsection of the neck right in here we call the subaxial spine, and the lower junctional segment between the neck and your trunk. And you get injuries throughout the spine, arthritis throughout the spine, and malalignment issues throughout the spine, all of which may benefit from a surgical evaluation by someone like me who specializes in spine surgery and cervical spine surgery and deformity or scoliosis surgery. For more information, please call 631-376-4444 or visit good-samaritan-hospital.org. Again, I'm Dr. Brian McHugh. It's been a pleasure speaking with you today. Have a good rest of your day.